Good evening, and welcome to our webinar tonight on the biologics for chronic rhinosinusitis with nasal polyps, the who, when, why, and which one. I'm Whitney Stevens from Northwestern University, and these are my disclosures. Tonight, we're going to be reviewing patients who have CRS with nasal polyps, looking at the different factors that can impact disease burden. We're going to talk about the best practice criteria for when to recommend sinus surgery or biological therapy. And then we're going to differentiate and talk about the different biologics that are currently approved for the treatment of CRS with nasal polyps, or I'll also refer to it as CRS-WNP. So why do we care about chronic rhinosinusitis with nasal polyps? Well, it can impact a large majority, or can impact a lot of people in the US. And also it's important because it is associated with a significant disease burden in patients. Not only do patients with CRS with nasal polyps report having problems with sleep and physical functioning, nighttime awakenings, they also have impact, as shown over in orange, with their work, with social life, and just their overall feeling annoyed and their emotional well-being. And there's different ways now that can help a physician assess a patient's quality of life and how CRS with nasal polyps can impact their disease. There are some questionnaires, as shown in the bottom with SNOT-22, the CSS, RSDI, RQLQ, and several others that are looking that the patients can take these questionnaires and they can report on their sinus symptoms such as headaches, facial pain, nasal discharge, blocking, congestion, loss of smell. But some questionnaires can also focus on their how the disease is impacting their quality of life. What's their quality of sleep? How tired? What are their energy levels? How is their mood? And how does this potentially impact their daily activities or work? Additionally, from Northwestern, there's a CRS Pro, which is a 12-item patient-completed questionnaire that can assess the impact of CRS in the prior 7 days. It's only 12 questions, and again, it is concise and valid and is a reliable measurement of the impact of CRS on a patient. And that this tool was developed with extensive input from patients who are suffering from CRS, and it correlated highly with SNOT-22 and validation studies. So again, patients can rank their symptoms as either not at all the way to very much. In addition to having a burden on patient quality of life and how a patient feels, the economic burden of CRS with nasal polyps is also staggering, with the total annual economic cost associated with CRS estimated to be about $5.7 billion annually. More indirect assessments would be that it's been associated with 4.8 days of missed work each year. And for patients who have inadequately controlled CRS, the indirect costs can be estimated at $7,182 per patient per year. So if you add all this up, the total cost of CRS per patient in the United States can exceed over $15,000. Again, showing that there are patients with CRS who not only have physical impacts of the disease, but also there's a large economic component. Now, CRS doesn't exist always by itself, and it's important as a clinician or surgeon to identify if there are other comorbidities associated with the disease. Asthma in the middle is associated and is seen in about half of patients who have nasal polyps. And there's a subset of patients who have nasal polyps, or chronic sinus disease with nasal polyps, plus asthma, but additionally have an intolerance to COX-1 inhibitors. So these patients who have CRS with nasal polyps and asthma and also report having difficulty taking aspirin or ibuprofen because they say within minutes to hours of taking these medications like NSAIDs, they can develop worsening sinus symptoms as well as asthma exacerbations. And patients with this clinical triad have aspirin-exacerbated respiratory disease, and it's estimated that about 10% of patients who have CRS with nasal polyps actually have AERD. And then finally, on the right, you can see that there is a high prevalence of allergic rhinitis among patients with CRS with nasal polyps. Whether we don't necessarily think allergic rhinitis contributes or causes CRS with nasal polyps, but again, is a comorbid finding. And so when patients present to you with nasal polyps and chronic sinus disease with nasal polyps in particular, it's important to ask about asthma, important to ask about medication allergies, especially if they can tolerate aspirin or ibuprofen or similar products, and also evaluate for allergies. Now, it is estimated that if you have one of these comorbid diseases, such as asthma, it has a higher likelihood of having undergoing a revision sinus surgery. So patients with CRS who have a relevant comorbid condition in this study were up to 4.7 times more likely to undergo at least one revision surgery in the 10-year follow-up window compared to patients who didn't have one of these comorbidities. So again, 4.7 times more likely to undergo at least one revision surgery compared to patients who did not have a comorbidity. So now that we have kind of introduced chronic rhinosinusitis with nasal polyps and talked about how it can impact symptoms as well as if there's an associated financial cost, we're going to switch gears a little bit to understand what's driving this disease process. What are the underlying pathogenic or molecular drivers that's been associated with CRS with nasal polyps? And this is important not only to remind you of basic immunology, but also to provide a context of which the biologics that we'll be talking about were thought to even be effective or potential options for treatment of patients with this disease. So there are different inflammatory endotypes that have been associated with chronic rhinosinusitis. And you might ask, well, what is an inflammatory endotype? So there's different types of immune responses that can be generated. And these immune responses comprise different types of cells. For example, in a type 1 immune response or inflammatory endotype, the cells that you would typically see in this response would be CD8 T cells, type 1 Th1 CD4 T cells, macrophages, as well as NK cells. And the predominant cytokines produced would be interferon gamma and IL-12. Moving on to type 2 inflammatory endotype, which allergists would be more familiar with, this inflammatory endotype is associated with eosinophils, basophils, mast cells, CD4-Th2 cells, innate lymphoid cell type 2 or ILC2s, as well as type 2 macrophages. And the predominant cytokines observed in the type 2 inflammatory environment would be IL-4, IL-5, and IL-13. And then finally, there's a type 3 inflammatory environment or endotype where you would see predominant neutrophils, a type 7 or CD4-Th17 cells, and innate lymphoid cells type 3. And the predominant cytokines produced in the type 3 endotype would be IL-17 and IL-22. So this is a very busy slide, but it's to tell you that patients with CRS and WNP, at least in the United States, are more likely to have a type 2 inflammatory endotype. You can see predominant ILC2s, mast cells, basophils, eosinophils, and higher productions of IL-4, IL-5, IL-13, and other inflammatory mediators, again associated with type 2 inflammation. So if we go back, and again, nasal polyps in the United States are associated mostly with a type 2 inflammatory pattern. And I stress that this is in the United States because historically in Asia, patients with CRS with nasal polyps did not have a predominant type 2 inflammatory infiltrate. However, over the past decade, the type 2 inflammatory endotype has also been increasing in prevalence in Asia. Back in the United States, like I said again, type 2 inflammation is the most predominant inflammatory endotype in nasal polyps. However, there are some patients that have a predominant type 1 or a type 3 inflammatory endotype. And indeed, there are some patients that have mixtures of type 1 or type 2 or type 3, or even none of the above. And so moving forward again, when you see a patient, we aren't at this state where we can say just based on looking at them what type of inflammatory endotype they have. But again, the majority of patients would fit into this type 2 inflammatory pattern. So we'll go to our first case of John, who's a 41-year-old male who comes to you with a history of postnasal drip, decreased smell, sinus pressure and pain, and he was diagnosed with asthma in his mid-20s, and he recently had rhinorrhea and a seasonal cold. For his symptoms, he's been taking over-the-counter nasal steroids as needed for symptomatic relief for the past 2 years. If he has symptoms, he'll take it, but again, if otherwise, he doesn't take it daily. He's also on a low-dose inhaled corticosteroid for the past 10 years. When you either do an endoscopy or you look in his nose, you can see bilateral nasal polyps. So the first question for you is that John's clinician orders a CT scan of his paranasal sinuses and then tells him to come back in about 30 days. In the meantime, how would you treat John? Would you prescribe intranasal steroids for regular use? Would you prescribe short course of oral corticosteroids or OCS and recommend regular intranasal steroid use? Would you refer him for a FES, which is a functional endoscopic sinus surgery, or would you initiate a biological therapy? So right now we have the winner of our polling is 40% of you all would start a biologic therapy, 30% would prescribe a short course of oral steroids and recommend regular intranasal steroid use, followed by 20% with intranasal steroid for regular use without the oral corticosteroid burst, and then 10% would prefer to surgery. All right, let's see what we would do. So we'll start with medical management of patients, which in a patient who's surgery naive, it would be appropriate to start with medical management, but also appropriate to consider the extent of disease and consider a referral for surgical evaluation. So standard of care for medical management, the gold standard is intranasal corticosteroids. Now, this can come in many different flavors of steroids, including what we're most familiar with, which is the over-the-counter nasal sprays. Additionally, and I'll talk about this in a minute, but there's a new delivery system for intranasal steroids, the EDS flu system, which I'll talk about shortly. And then also intranasal steroids can be delivered through rinses, instillations, and drops. Other things to consider for medical management would be oral corticosteroids, but this is really just for acute relief, and it's not recommended for long-term use, and we'll talk about why that is in a little bit. And then there's also saline rinses or saline irrigations. And there's some studies have shown that there's some benefit compared to placebo using these large volume irrigations. However, there's not a lot of large scale randomized placebo controlled studies looking at, saline irrigation. And then finally, antibiotics are not recommended as initial gold standard of care for patients with chronic sinus disease. However, patients who are having an acute exacerbation that is of a bacterial origin, it would be appropriate in these circumstances to give antibiotics. So going backwards a little bit to talk about the newer kid on the block per se, the exhalation delivery system with fluticasone. What it is you can see here that the patient, there's a part of the nose spray that will insert into the nose, and then there's a part that inserts into the mouth. And instead of a traditional spray where the patient will squirt or the nose spray directly into the nose, here the patient breathes into the mouthpiece, and that breath actuates the spray of the fluticasone into the nose through the posterior sinus cavity. In the study for FDA approval, and this was a phase 3 Navigate-2 trial, they evaluated patients with moderate to severe CRS with nasal polyps and found that polyps were eliminated in 25% by 25% at least one side by week 24, compared to only 8.7% with placebo. And this was also associated with a reduction in SNOT-22 score, or an improvement in the score. So, or improvement in symptoms. So patients had less polyp size, or polyp size was reduced. Symptoms improved using this fluticasone in the exhalation delivery system compared to placebo. It should be noted in this study that it was not compared to fluticasone given in a more traditional way, again, just with placebo. Additionally, other things to think about for management of patients with CRS with nasal polyps is, again, to consider patients or referring patients for endoscopic sinus surgery. However, patients still will need intranasal corticosteroids after surgery to help prevent the nasal polyp regrowth. And then additionally, steroids, besides being delivered through sprays or drops, they are now stents available that have steroids that can slowly elute from over, for example, a 90-day period. And this also can help prevent the need for revision surgeries. So back to our patient, John, who's a 41-year-old male. The clinician prescribes a short course of oral corticosteroids to be started after the CT scan, as well as to start on an intranasal steroid daily or regularly, as opposed to how he was using it before, which was just kind of as needed. He says that when he was taking the oral steroids, his symptoms improved, but then after he stopped the oral steroids, they started to come back, and now they're really back. He says that he's been taking his fluticasone daily, and the results of the CT scan that you ordered comes back and shows, again, bilateral nasal polyps with moderate opacification. When you think about the other options presented in that quiz, starting a biologic in this patient, while it may be indicated depending on his disease status, he really hasn't tried other therapies, including the gold standard first line. So instead of jumping to that, it is usually recommended that they start the first line therapy with a regular nasal steroid spray, see how he does, and then consider escalating from there. So now he started his first line therapy of the nasal steroid spray, and it's okay, but he's still having symptoms. So now the question is, he's coming in for additional options. What therapy would you recommend now? Would you prescribe EDS flu? Would you give him another course of low-dose oral corticosteroids? Would you evaluate and refer him for sinus surgery, or would you initiate a biologic therapy now? So we have prescribed EDS flu at 31%. We have another 31% referring for surgery and 39% initiating biological therapy. So that's great that no one wanted to do low-dose oral steroids again. Yes, you could try EDS flu. You can refer for sinus surgery. You can consider initiating a biologic therapy. But again, this patient is surgery naive. So I would tend to refer to surgery first, but we'll talk about when to refer for surgery versus biologic later in the talk. But again, great job everyone for not recommending another low-dose oral steroids. And why we would say that is there's a lot of side effects associated with cumulative oral corticosteroid use. So yes, it can work in bursts, but if you're finding yourself always needing bursts and another burst and another burst, the patient's at risk for adverse side effects from all the oral corticosteroids. We don't have to get into all of them, but again, a higher risk of osteoporosis, type 2 diabetes, cataracts, lots of different bad side effects of cumulative oral corticosteroids. So again, when you start finding those patients that you need to you feel like all they're doing is just getting temporary relief from oral corticosteroids, we need to escalate care. So this talk is not focused on sinus surgery, but more focused on biologics. But again, it's important to consider sinus surgery for your patients who have CRS with nasal polyps. But we're going to focus on the biologics. And currently, there are 3 FDA-approved biologics for CRS-WNP. Now, if you remember a little bit about the immunology we talked about earlier, dupilumab is a monoclonal antibody that targets the IL-4 receptor alpha chain. Now, by blocking this receptor, you're blunting the effects of both IL-4 and IL-13. Dupilumab is currently approved as add-on maintenance for adults with uncontrolled CRS. And its dosing is 300 milligrams every 2 weeks. Omalizumab, which targets soluble IgE, is also approved for patient add-on maintenance therapy for adults with an adequate response to intranasal corticosteroids who have nasal polyps. The dosing of omalizumab is weight-based as well as IgE-based. And then mepolizumab is targeting soluble IL-5, again, approved for the treatment of nasal polyps. And this is given subcutaneous every 4 weeks. The safety across all the clinical trials for nasal polyps were similar. And so we're going to take a minute and go through some of the clinical trials for these agents. If you look at dupilumab, there were 2 studies done, Sinus 24 and Sinus 52, and these were phase 3 clinical trials. And you can see on the left is the Sinus 24 with placebo in gray and dupilumab in kind of an orangish color. And you can see that on the top, you'll have nasal polyp score, and on the bottom, the patient-reported nasal congestion or obstruction score. And so dupilumab in the Sinus 24, which was treatment that ended at 24 weeks, you can see that there was a significant improvement in nasal polyp size, as well as an improvement in patient-reported nasal congestion, again, compared to placebo at 24 weeks. Now, what's interesting is after 24 weeks in the Sinus 24, the patients were discontinued the treatment was discontinued, but they were still followed. And you can see that their nasal polyps started to grow back, and their nasal congestion and their symptoms started to recur. This suggests that dupilumab is not curative because when you take the therapy away, their symptoms do come back. If you look at the Sinus 52, which was just a longer study, you can see that, again, compared to placebo, the patients did report over a longer period of time improvement in their nasal polyp score, aka reduced polyp size, as well as improved nasal symptoms compared to placebo. If another feature that they looked at was the need for oral corticosteroids or surgery. And this is looking at the percentage of patients in the pooled analysis of both the Sinus 24 and Sinus 52 who needed either oral steroids or had underwent sinus surgery during the trial. And you can see that the patients in the placebo group were more likely to receive oral steroids or undergo surgery compared to dupilumab. And this was a statistically significant difference. The next study that we'll look at is omalizumab. And this is looking at the polyp 1 and polyp 2. And this is also looking at an extended study of this. So on the left, you'll see the nasal polyp size or score, which is how big is the polyp. And then on the right, you'll see the nasal congestion or symptom assessment. From 0 to 24 weeks, you can see the results of the two studies, and you can see that the patients on omalizumab, which is in red, had an improvement in their nasal polyp size, as well as an improvement in their nasal congestion compared to placebo or those off drug, which was in blue. Then you can see that between 24 and 52 weeks, that all patients were put on drug. And then during that period of time, the people that were originally on placebo or off omalizumab, when they were put on the drug, they also had a reduction in symptoms and nasal polyp size. Then at week 52, the drug was stopped in both groups, and you can see that, again, there's a return, or their nasal polyps start to grow, and there is also their nasal symptoms started to recur. So similar to dupilumab, you have an improvement in symptoms and nasal polyp size on the drug, but when the medication is discontinued, the symptoms recur. Additionally, looking at reducing the need for surgery, it was found that there was a reduction in the need for surgery for the patients who were on drug compared to off drug. And then finally, this is looking at mepolizumab, again, the biologic targeting soluble IL-5. And you can see, looking here, that there's the placebo in gray and those treated with mepolizumab in blue. And you can see here that the nasal polyp score is on the left and the nasal obstruction score is on the right. And there is more patients on the mepolizumab in blue had a 1 or 2 or 3 or 4 point improvement in symptoms and nasal polyp size compared to patients on placebo. So another way to look at this graph is there's more blue towards the right, which is showing improvement, and there's more gray on the left, which is not improvement. And then another endpoint that they looked at was the need for sinus surgery, placebo being in gray and mepolizumab being in blue. And you can see that over time, the probability of needing a surgery for your nasal polyps was higher in the placebo group compared to the mepolizumab treated patients. There are other biologics that are currently in studies for the evaluation of treatment with CRS with nasal polyps. Benralizumab is interesting because earlier this year, the FDA declined to approve it for nasal polyps based on the trial, but there is a second trial that is undergoing, the ORCID trial, that is continuing to look at the efficacy of benralizumab in eosinophilic nasal polyps, the study of which is ongoing. There are 2 other medications, tezepelumab, which is targeting TSLP, and depokinumab, which is a longer-acting IL-5 agent targeting IL-5 that's also being looked at in the disease. We don't have outcomes from these studies, again, because they're ongoing, but additional treatment options are available. So now that we've talked about the biologics that are currently FDA approved, as well as we've mentioned that more are coming, the question facing a lot of physicians at this time is, well, who do we give biologics to and when is the appropriate time? So there have been several different consensus guidelines that have been published that are trying to help physicians answer the question of who and when. So in the next 3 slides, we'll go through the different guidelines that are currently available. So for example, this is a multidisciplinary management algorithm and for patients with CRSwNP. And following this algorithm, the majority of patients, it's recommended to undergo sinus surgery if they have not already. And then after sinus surgery, post-operative management, including continuing intranasal corticosteroids, as well as saline irrigations and other options should be discussed. If the disease recurs despite surgery and post-operative management, then a shared decision-making needs to be had with the patient in terms of what the next step would be. Would this be a repeat sinus surgery or revision sinus surgery? Would this be initiation of a biologic? Would you want to use a steroid sinus implant? And then for patients specifically with AERD, the discussion of whether they would need an aspirin desensitization followed by high-dose aspirin therapy should be held. It's really important to stress that a aspirin desensitization and high-dose therapy is not effective in patients with just CRSwNP, but it is something that could be considered in patients who have AERD. However, it is best done and recommended to be done, the desensitization therapy after sinus surgery when the polyp burden is low. There are some patients who are just not a candidate for surgery, such as patients with poorly controlled asthma, or those who just don't want to undergo surgery at all, and in which case, in the minority of patients who have these contraindications, a biologic could be considered more upfront. Switching gears to the European guidelines, the euphoria criteria. So what this guideline recommends is that if you have nasal polyps, you then want to think, has the patient ever had sinus surgery? If they've had a history of sinus surgery before, then 3 of the criteria that I'm going to talk about below are needed to consider starting a biologic. If there is no history of sinus surgery, then you would need 4 of the criteria I'm going to talk about below to initiate a biologic. So there needs to be evidence of type 2 inflammation, elevated eosinophil counts, for example. There needs to be a use of systemic corticosteroids for at least 2 or more courses in the past year. The patient must report a significantly impaired quality of life. They must have a significant loss of smell and the diagnosis of comorbid asthma. So again, 3 of these criteria are needed to start a biologic if the patient's had a history of surgery, while 4 of these criteria are needed if there has been no history of surgery in the past. And then finally, another guideline, the EPOS 2020 steering group has a slightly different criteria. And this is for patients who have had sinus surgery. So this is, again, they say there are some exceptional circumstances for patients who are not fit for surgery, but it's recommended patients have surgery. And if they have failed this, the presence of bilateral polyps in the patients who's already done sinus surgery, you need 3 of these criteria. Again, evidence of type 2 inflammation with elevated blood eosinophil count, elevated IgE, or elevated tissue eosinophil count. That one's a little harder to get in terms of from a routine clinical exam. There has to be prior use of systemic corticosteroids, such as greater than or equal to 2 courses per year, or long-term greater than 3-month low-dose steroids. There should be a significantly impaired quality of life, a significant loss of smell, and then again, a diagnosis of comorbid asthma. So again, there's three different ways in which you can assess a patient. So if we go back to our patient who has not undergone sinus surgery, but is having symptoms despite having used the intranasal steroid spray, if you think about the multidisciplinary consensus, he is a candidate for surgery based on his profile. We don't have any known contraindication for him now. And we don't, we should assess his asthma, but I'll say it's well controlled. With the euphoria guidelines, he does meet criteria despite being surgically naive, because he does have for criteria of comorbid asthma, loss of smell, need for systemic corticosteroid bursts, and he has evidence of type 2 inflammation with elevated eosinophil counts. And then, however, using another criteria, because he hasn't undergone sinus surgery yet, he would not meet criteria based on these guidelines. So, at the end of the day, I think having, using your clinical judgment and having a shared decision-making with patients with CRS is very important when thinking about the next steps of treatment when they're failing initial frontline therapy. And of course, it is possible, and like we've alluded to before, patients can undergo sinus surgery, and even despite post-surgical management, they can have recurrence of their nasal polyps. In some studies, nasal polyp recurrence after surgery has been reported in 20 to 35% of patients at 6 months and 40% of patients at 18 months. And so about a third of patients require repeat surgery over 12 years. And what we're trying to do is identify or come up with a way to identify which of these patients are going to be the ones that are going to need the recurrent or repeat surgeries versus the patient where there's one surgery and then they're well controlled. Right now, we don't have a good clinical biomarker for this, but studies are underway trying to help the clinicians better identify which patient may be the one that needs, again, the recurrent surgeries. So if you're thinking about using a biologic, I've told you that 3 are currently FDA approved. And so the question is, okay, you've talked with the patient, you've decided that yes, a biologic is the appropriate treatment for the patient, but now you're like, I have 3, which one could I choose? Unfortunately, there are no head-to-head studies comparing dupilumab to omalizumab to mepolizumab. And so I cannot tell you which one is necessarily better because we don't have any head-to-head studies. There is a study ongoing looking at dupilumab versus omalizumab, but we don't have the data from that currently. So the best we have is people that have done systematic reviews, trying to look at the data that's been published in the separate clinical trials to see if there is a winner per se. But again, this is not head-to-head. So it looks like dupilumab may be better for improvement in sense of smell and quality of life versus placebo. And I want to stress this is each of these is versus placebo. And then there was another study that was an indirect treatment comparison of the 2 randomized control trials for dupilumab versus omalizumab. Again, this is not head-to-head, but this is taking the data from each study and then doing an indirect treatment comparison. And doing these analysis, it does look as though dupilumab, the data suggests that dupilumab is more favorable than omalizumab in nasal polyp score in improving nasal congestion and in improving loss of smell. So based on indirect treatment comparison in this study, dupilumab may beat out omalizumab, but again, we need to, it would be great to have the information from the head-to-head studies for which drug may be better. So we're going to move on now to our next patient, who's a 34-year-old woman who presents, we know that she's had CRS with nasal polyps. She's had smell loss for the past 3 months. She's had 2 sinus surgeries in the past. This is not, she's like, I get the surgery, I feel better for a little bit, and then it just gets worse again. And then I get another surgery and then I feel a bit better. And then all my symptoms get worse again. She's needed 2 courses of steroids in the past 18 months. Additionally, she has comorbid asthma. It is controlled with a inhaled corticosteroid inhaler. And additionally, she says that her sinuses got horrible congestion, horrible postnasal drip when she took ibuprofen after a recent foot surgery. And during that time, she also had to use a rescue inhaler because she felt that her asthma was starting to flare after ibuprofen use. So this patient's clinically telling you she has aspirin-exacerbated respiratory disease. Patients with ARD tend to have the most severe form of CRS. They tend to require multiple sinus surgeries for control of their disease. And also, it's not surprising that she's had to have several courses of prednisone to try to improve her symptoms. But when she stops the prednisone, her symptoms just come right back. So the question is, in this patient who has AERD, what would you do next? Would you do a short course of oral corticosteroids again? Would you consider her for a revision sinus surgery? This would be number 3. Would you start a biologic? Would you do a short course of steroids plus a revision sinus surgery or biologic? That's the catch-all. Would you consider a steroid sinus implant, or would you talk to her about an aspirin desensitization followed by high-dose aspirin therapy? So the winner, not surprisingly, is a biologic treatment, which I would tend to agree with here. Also, a short course of steroids plus a revision sinus surgery or biologic, yes, that could also be considered. If she's truly miserable, the short course of steroids might help her. But again, when you stop it, all her symptoms will come back. But again, you're considering sinus surgery or biologic. And I think in this patient, having that discussion, you've had 2 sinus surgeries. Do you want to consider a third one? Also, the quality of the sinus surgery should also be considered. So referring to ENT for evaluation may not necessarily be a bad thing, because you want to make sure they've had good quality surgeries and are failing good quality surgeries. Additionally, an aspirin desensitization followed by high-dose aspirin therapy would definitely be an option for this patient. You would have to make sure her asthma is well controlled, which we said that it was. But if she has a high polyp burden, she would need to undergo sinus surgery first to then undergo the aspirin desensitization. So it's something to consider in these patients. Again, if they're willing to undergo surgery, but if they have a very high polyp burden, just desensitizing them and putting them on high-dose aspirin won't shrink the polyps that they have. So again, I would tend to go with the biologic over the surgery here. But again, there's other factors that need to be considered. What would the patient like? What would the patient prefer to do if you present all the risks and benefits associated with the options? So if you go to the consensus, we'll see if we're right. She has the symptoms have persisted or recurred despite surgery. So biologics could be considered, again, with the other options. When looking at the euphoria guidelines, she definitely meets criteria for biologics. She has the history of sinus surgery. And then for the EPOS 2020, again, she meets criteria because she has the history of surgery, the asthma, the smell loss, needing more steroids in the past year. So again, I would tend for biologic here, but the patient may want to do surgery. So I think employing clinical judgment and shared decision-making, again, is very important in these patients with CRS with nasal polyps. And also talking about risks and benefits of an aspirin desensitization because she has AERD. If she did not have AERD, you wouldn't need, the aspirin therapy would not be beneficial. So again, looking at subgroup populations, looking at patients here with the asthma with or without AERD, and then in the second row, looking at patients with AERD, you can see that in the indirect treatment analysis that dupilumab was kind of edged out omalizumab in terms of the asthma subgroup and nasal polyp score and congestion. And then also you did see a slight difference with dupilumab edging out omalizumab in the nasal congestion score for AARD patients. But again, talking about to the patient, if you want to choose a biologic, talking to them about how it's administered, how frequently it's administered, may also impact the patient's decision. So in the last bit of time that we have, kind of the key decision-making, the key points to bring up is it's really important to have this shared decision-making for patients. Talking about intranasal steroid sprays versus using the EDS fluticasone, risks and benefits of surgery, as well as risks and benefits of biologics. It's also important to weigh the cost of these medications, intranasal corticosteroid sprays over the counter, and then you have the more expensive therapies with surgery, and then biologics can in some patients be cost prohibitive because of insurance coverage. So it's important to take all of these factors in together when talking to a patient about what therapies they might be interested in doing. And again, this is just a review of the different biologics that we talked about. The dosing, again, is with dupilumab, it's every 2 weeks. With omalizumab, it's based on total IgE and weight. And then mepolizumab is every 4 weeks. There have been some warnings associated or some side effects that you need to monitor for in these conditions. With omalizumab, especially while no anaphylaxis was reported in the CRS studies, there has still been an association of anaphylaxis with administration of the drug. And then with dupilumab, conjunctivitis has been associated with dupilumab, but it has occurred less frequently in the nasal polyp population compared to the atopic dermatitis population. And then unmasking potentially a vasculitis, eosinophilic vasculitis would be something that has been seen in a few cases with dupilumab. So we're going to go through some of our post-test polling questions. First off, patients with CRS with nasal polyps and a relevant comorbid condition were up to how many more times likely to undergo at least one revision surgery during a 10-year window compared to patients without the comorbidity? 2.7 times, 3.7 times, or 4.7 times? Excellent. The answer is 4.7 times. So everyone has done well and has paid attention during the lecture. That's fantastic. So again, the correct answer is 4.7. All right, next question. According to EPOS 2020, in order to meet criteria for the need of systemic corticosteroids in consideration for a biologic treatment of CRS, the patient should have which of the following? 1 short course of steroids per year with long-term therapy greater than a month, 2 short courses of oral steroids per year or long-term oral steroid treatment for more than 3 months, or 3 short courses of oral steroids per year or long-term oral steroid therapy for greater than 6 months. Excellent. The correct answer, which most everyone got, was greater than 2 short courses of oral steroids per year or a long-term oral corticosteroid therapy greater than 3 months. Good job. Question number 3 is the 45-year-old male with CRS that's impacting quality of life. He has asthma, for which he's taking a medium dose inhaled corticosteroid. He's been treated with EDS fluticasone for the past 6 months and was previously taking a daily regular intranasal corticosteroid. He has completed 2 short courses of oral corticosteroids after losing his ability to smell. Smell came back when he was on the oral steroids, but then worsened again when off. He has not had surgery, so what would you recommend? This one's okay. So there's surgery, and then there's also biologic. So for here, based on this patient who is steroid naive, he does meet the euphoria criteria for having, he does have significant impact of quality of life, comorbid asthma, loss of smell, and he's had he's had 2 courses of steroids. So based on those guidelines, biologic therapy, he is a candidate for. Based on another guideline, because he's surgery naive, it would be recommended for surgery. So again, both of those options would be, depending on what guideline you follow, would be available. Personally, I would probably go with surgery first and then biologic, but you would have to talk to the patient. Maybe there's a reason he doesn't want to do surgery, in which case a biologic would be a totally reasonable option. Finally, and the last question of the evening, a subgroup analysis of patients with CRS and asthma and an indirect treatment comparison found statistically significant improvements in nasal polyp score and nasal congestion in patients with or without AARD, and in congestion in patients with AARD for which of the following? Was it looking at dupilumab versus omalizumab, omalizumab versus mepolizumab, or mepolizumab versus dupilumab? Essentially, what was the study that did the indirect treatment comparison on what 2 drugs were studied? Correct. So good job, everyone. Dupilumab versus omalizumab were the 2 studies that they compared. And we, again, I wish I could tell you which one was the best one to use, but we don't have any head-to-head studies, so that I can't say that for sure. But again, based on the indirect treatment comparison, dupilumab did seem to be superior to omalizumab in certain aspects. But again, we need those studies, the head-to-head studies, to really answer the question. But I think in real life, right now where we stand, talking about each of the options for these patients and talking about the risks and benefits associated with each one, as well as the dosing frequency and, of course, insurance coverage, may dictate which one the patient would prefer. So with that, hopefully we've talked today and you've learned about the patient, the burdens, both symptom and the impact of quality of life, as well as the economic burden CRS with nasal polyps has on affected patients. We have talked about, if you want to try to assess the symptomatic burden on patients, there's different questionnaires that are now available that can help you figure out quality of life and how much this is impacted in patients. Some surveys focus more on nasal symptoms. Other surveys will include quality of life, mood, and other extranasal symptoms in their surveys. Additionally, intranasal steroid therapy is the first-line gold standard of care for patients, and you can do systemic corticosteroid bursts. However, there are lots of adverse effects associated with repeated courses of oral corticosteroids, and those usually outweigh the advantages of the benefit of doing long-term use of oral corticosteroids. Now, there are several, so then when you think about, well, the patients failed our first-line therapy, what should I do next? There are several consensus groups have come up with guidelines. And there are subtle differences between the guidelines that you've seen regarding when to pursue surgery versus a biologic versus another treatment for CRS with nasal polyps. And currently, this talk was more geared towards biologics, but you can see that there are 3 biologics currently approved: dupilumab, omalizumab, and mepolizumab. And there are other biologics currently in the pipeline undergoing clinical trials, so there may be even more options for patients in the future. And like I've stressed before, in the absence of head-to-head trials, indirect treatment comparisons are the best we have yet to provide support for how to select a biologic for a potential individual patient. But what we're really needing is some way of knowing which patient you see in clinic is the one that's going to have the recurrent disease, which patient is the one that's going to do better on one biologic versus another. And right now we don't have ways to assess this, but hopefully in the future we will. And then finally, it's always important when evaluating a patient with CRS for other clinical comorbidities, especially asthma and especially aspirin-exacerbated respiratory disease, as patients with these conditions have generally more severe CRS. And those patients with CRS and comorbidities are 4.7 times more likely to undergo revision surgery or have more recalcitrant disease. So with that, I'd like to thank you all for your time this evening. Again, thank you for coming tonight for the webinar.